Sural nerve biopsy may typically be done under conscious sedation. The patient is positioned supine with a large gel or blanket roll under the hip ipsilateral to the site of biopsy. The leg and ankle are then supported to allow access to the lateral malleolus. An incision is planned midway between the lateral malleolus and lateral edge of the Achilles tendon. It should be sufficient to provide about 5 centimeters of nerve. Incision is made through skin into subcutaneous fat. Dissection hereafter should proceed with blunt dissection and parallel to the course of the nerve to avoid nerve injury. Often the lesser saphenous vein is first encountered and may be mistaken for the sural nerve. The vein is often characterized by branches that arise at right angles. The sural nerve usually found just medial and deep to the lesser saphenous vein. It is characterized by the typical striated pearlescent appearance of a nerve and no branches until distal in its course at the level of the lateral malleolus. The nerve is cleared from soft tissue attachments proximally. It is important to keep the nerve moist until placed in fixative solution. The nerve is ligated with a silk tie. This aids in applying traction for another silk tie, which should be placed as proximal as possible. This step may cause brief but significant pain, and coordination with anesthesia allows optimal analgesia. It may also provide reassurance that the nerve has been appropriately identified. The nerve is cut proximally. The nerve is then dissected and cut distally. The patient does not feel this cut if the first cut is performed proximally. Nerve fascicles should be confirmed on the cut ends. Appearance of a lumen signifies likely a vein has been obtained in error. The proximal nerve epineurium is now infiltrated with plain local anesthetic. Infiltration prior to this risks disrupting the specimen. The cut end is buried deep in muscle, proximally, to avoid entrapment in scar and formation of a painful neuroma. The wound is closed with deep dermal sutures and a sterile dressing applied. Postoperatively, the surgeon confirms preservation of dorsiflexion and eversion, as well as an expected area of sensory loss in the lateral foot.